Welcome, and thank you for joining us. My name is Alixe Bonardi from Human Services Research Institute, or HSRI. HSRI is one of the conveners of the 2021 Reinventing Quality Conference. The theme of this year's conference is Lessons Learned from 2020, Managing and Leveraging Disruptions. I'm very pleased to introduce this session of the 2021 Reinventing Quality meeting. All sessions are being presented semi-live, which means that content you are about to see has been pre-recorded, but the presenters are all live with us and available in chat, and looking forward to answering questions or responding to comments over the course of this hour. The session title is Mental Health Approaches to Challenging Behavior for Persons with Intellectual and Developmental Disabilities, Using Positive Practice to Shape Change. As a reminder, the presentations will be delivered back-to-back over the course of the hour, that is without a break for questions between presentations. I encourage you to begin a dialogue with the presenters in the chat right now and not to wait until the end of the presentations, as there will be extremely limited question and answer time at the end of this presentation. Thank you everyone for joining us. And again, I encourage you to begin using chat right away to connect with our panelists.
Hi, thank you for joining us for this session on mental health approaches to challenging behavior for persons with intellectual and developmental disability. We're going to focus today on using positive practice to shape change. My name is Melissa Cheplic, and I'm joined by my colleague, Tony Thomas. I am a training and consultation specialist at the Boggs Center, which is our university center at the Rutgers University in New Jersey. I work as a trainer and a consultant, supporting people in helping identify how mental health can lead to behavior challenges that people have. And I work with teams and families to help people have a better life by addressing mental health and behavioral health challenges. And I work with Tony through NADD, National Association on Dual Diagnosis, where we do a lot of things together, but also help direct support professionals have empowerment and competency to also do the same work in building capacity in behavioral health. So Tony, tell us a little bit about yourself and what you do.
Sure. Hi, Melissa, thanks. Again, delighted to be here today. Want to thank the staff that helped put this together as well. So my name is Tony Thomas. I'm Executive Director of Welcome House, and Welcome House is an agency serving people with developmental disabilities in the Cleveland, Ohio area. We serve 185 persons with developmental disabilities, along with a staff of about 375 people. I've been at the organization for 22 years and have done a lot of work with the National Association of Dual Diagnosis, and have constantly been learning more and more great things through my association with NADD about how to help persons with developmental disabilities deal with some very difficult and challenging situations, especially as it comes to mental health, which has been a topic that Melissa and I have talked about, written about, and presented about. So Melissa, I'm going to give it back to you. Thanks.
Great. So we look forward to talking with you today about ways that we can really recognize how mental health can lead to some ways that people struggle with their behavioral health, and ways that we can all be in a better position to really recognize that, both in micro ways and in macro ways in the work that we do. So typically when we talk about people with intellectual or developmental disabilities who have the experience of mental health, we think about that concept of dual diagnosis, right? Having a mental health challenge in addition to an intellectual disability. And we want to be mindful of those types of risk factors that exist for people with intellectual disability to have that co-occurring mental health issue, right? Those biological and medical concerns, things like a genetic disorder, visual impairments, hearing impairments, brain injury, genetic conditions and physical illness that might contribute to underlying causes, make the environment harder to navigate. We look at social and psychological issues, things like unemployment, underemployment, exclusion, trauma, segregation, racism, all of those things that can contribute to challenges in a person's life. We look at the family and things that may exist within a person's life cycle, from diagnosis to changes in caregiving to grief and loss. And all these other factors that may contribute to the onset of a mental health condition over the course of a person's life. And people with intellectual and developmental disabilities are more likely to have that secondary diagnosis of anxiety or a mood disorder or OCD or a trauma disorder over the course of their lifetime. And so we think about all these vulnerabilities that make people more likely or more at risk to have that secondary mental health disorder. So when we look at how this applies to our real life scenario, we want to be mindful of how some of the observable behaviors or things that we identify as problem behaviors or challenging behaviors are sometimes what are symptoms of mental health disorders that people are experiencing. So I want us to reflect on one of these common experiences that we all have, right? I know that the world has changed significantly for us over the course of the past 18 months, 19 months with this pandemic. We've all been at these changes that we've been having, relying on other people for information. Having our basic needs dictated by other people. Sometimes we've been in a shortage of food or supplies. We haven't been able to see our friends or our family. We've had to wait in places for a lot longer, maybe for groceries, maybe for restaurants. We haven't been able to take that vacation or celebrate that holiday the way that we've been used to. And even though things are improving and we're so grateful for that and everyone who's been on the front lines during that, we know that these challenges that we've all experienced are very real realities and challenges for people with disabilities, even in the absence of a pandemic. And so we reflect on that with a common experience we all have, which is waiting, right? We often wait, especially when we go to a doctor's office, even when we have an appointment. We often find ourselves waiting, such as this graphic depicted here. We get to our appointment, we end up waiting to see our doctor for maybe 15 minutes, half an hour, 45 minutes waiting for that appointment, waiting for our name to be called. And the expectations are maybe not always clear, the demands are high, and our rewards are low in those situations like that. So we think of, what are some good things to do while we're waiting for that appointment? Maybe read a book, talk to people around us, listen to our podcast or some music if we brought some headphones with us, catch up on work, make a grocery list, advocate for ourselves with a receptionist, have a drink of water, maybe take a walk, come back in a little while. But we can also think of some things that others might do in this situation that maybe aren't necessarily the best things. Things like being disruptive, maybe being rude to the receptionist, maybe making other people in that situation who are also waiting uncomfortable, getting up and leaving, right? Maybe not the best thing to do if we've already committed to waiting and we're not feeling well and we have our appointment. So we think of everything we need to do those things from the first list, right? The skills that we would need. Do we have language? Do we have vocabulary, communication skills, social skills, self-control? Do we have patience, self-regulation? All those many things that require us to manage our behavior in these common challenging situations. And we know that for some people with intellectual and developmental disabilities, they may not necessarily have the skills, or in situations like this, when the demands are high or folks are feeling stressed or they don't feel well, or they're anxious, or they're just uncomfortable. Even when we have the skills, it's really hard to use those skills, grab them and use them when we need them. So this is a nice opportunity for us to reflect on common situations that people find themselves in where, behavior becomes the way to get our needs met, as is the case for all of us. So we want to be more proactive, thinking about where behavior comes from, the experiences that people have had, When we think about what to do when we go to the doctor's office, maybe we're prepared with our book and our snack and our grocery list and some emails to return and a good Wi-Fi signal and our earbuds and a couple episodes of that Netflix show that we're going to watch, because we've been there before. We know what it takes. But for folks who haven't, maybe they don't know, right? We think about mental health, stress, anxiety, mood disorders, trauma. Those previous experiences, those mental health symptoms can absolutely interfere with how people behave in a particular setting, right? All of those challenges in the environment, the expectations that may be too high or too low based on other people's anticipation of a particular behavior. So it's difficult to navigate. What are we looking at sometimes? Whether we think about our clinical teams, caregivers, direct support professionals, it's very difficult sometimes to distinguish whether behavior that we're observing, right, is associated with a psychiatric disorder. Maybe it's a learned behavior, right? If I act disruptively in this setting, perhaps I'll get to leave or I'll get to see the doctor right away and I won't have to wait here anymore, right? And we see that happen so frequently, whether folks are doing what they have to just to get their needs met, as we all often do when we are feeling the need to get our needs met. Sometimes people are engaging in behavior because of a medical condition. Maybe there's something in the environment, something that's causing a challenge: light, sound, noise, temperature, crowds, other people, the unpredictability of being in a setting that might be unfamiliar, trauma, grief, loss, change. And sometimes it's difficult to determine in a given moment what could potentially be causing some of these challenges that people are experiencing. And the first thing that we see when people are struggling is behavior, right? We see observable signs of people's internal struggles. So we have here a list for you of potential mental health symptoms that often, when people with intellectual and developmental disability are experiencing these things, we often identify them as being problem behavior or challenging behavior, right? Someone's yelling, they're pulling their hair, they're crying, they're trembling. They're showing a change in affect. They're perseverating on a particular topic or event or item or thing, right? And so rather than just looking at these kinds of items that we see here through a behavioral lens, we want to look more clearly at potential underlying causes that could be contributing to them. And we want to be mindful of the types of events that could be leading to some of these symptoms, right? And the symptoms that could be triggering behaviors, right? People are uncomfortable. There could be a particular memory of trauma, something or someone in a particular space or a place is making someone feel threatened, right? Threats that are real or perceived can be causing someone to feel unsafe or uncomfortable, and someone's reacting to that. A side effect to a medication, feeling uncertain about a situation, having a negative interaction with someone in their environment. All these potential things that we can see here. Oftentimes we are only privy to someone's experience by virtue of recognizing their behavior. And so we want to be more proactive with having those tools to really be able to recognize behavior for what it is, which is only the expression of a person's entire experience. And so we see behaviors. We see a person's interaction with his or her environment, or we see the external manifestation of someone's internal experience. And that's just the tip of the iceberg, as opposed to everything else that could potentially be going on with a person. So you want to think about those kinds of things that can make a person, specifically a person with intellectual or developmental disabilities, more vulnerable to these types of behaviors, right? A mental health diagnosis, right? Having anxiety, having a mood disorder, having a history of trauma, right? Being uncomfortable because of the anxiety driven by OCD or fluctuations in mood or anxiety about a particular setting certainly makes behavior more likely. We also look at, communication difficulties, people's inability to communicate, or their language or vocabulary that may not be clear or known to people around them. Changes in sensory perception. People are hypersensitive or hyposensitive. Intolerance of uncertainty, low coping skills. These are the kinds of things that can make people more likely to have behaviors in certain settings. And so we want to make sure that as teams who are looking at behavior, we're being mindful of not only just seeing behavior in the context where it's occurring, but looking at all of these potential things that can be contributing to that behavior for this specific person, right? How is this person's experience informing his or her behavior? So we look at this example here, a person who is feeling anxiety. Maybe he or she has an anxiety disorder. Maybe he or she is feeling anxiety, as many of us have been over these past many months, being in a place like a grocery store when it's very crowded, right? The store is crowded. I can't find the items that I need. It's really noisy. I'm very uncomfortable when there's crowds here. Maybe in this example, this particular person can't communicate his or her discomfort. They don't have the skills to manage the anxiety. They have sensitivity, hypersensitivity to sounds in that particular environment. And so I knock things down from the shelves. I crash cart into things or people that are close to me. I scream at people and I leave, or maybe someone there asks me to leave. If we're only focusing on the sort of the top half of this graphic, right, really looking at behavior, all we see is behavior, right? If you only have a hammer, everything always looks like a nail. And if you're only looking at behavior, you're only going to see this part on top. Here's a person knocking things down, crashing into other people and screaming, and they're being asked to leave or they have to leave a place. But when we look at the underlying conditions or the contributing factors, specifically the anxiety here, we start to develop a better understanding of a person's experience. So one of the ways that we can identify these things really specifically, especially for this person, is to look more specifically at what are these things that are contributing to behavior. So we look at an assessment as a way to do that. We want to identify as a team, right? A team is anyone who is working with a person, observing them in their setting, direct support professionals, family members, clinicians, anyone who is really spending a good amount of time with the person, really identifying behaviors, but also understanding the context in which it occurs, understanding the needs that are being met. Here's a nice way that we can use a tool to separate some of the factors of this behavior pattern, right? We tend to look oftentimes at ABC data, antecedent, behavior, consequence. What's the trigger? What's the behavior? What's the consequence? But when we look at things through a mental health perspective and we identify diagnoses that can be leading to behavior, we want to pay attention to those setting events. We want to look and see, well, what goes on even before the antecedent that could potentially be informing the trigger, really a setting event, setting up the person, right? Really contributing to the presence of that trigger. So we look at that example in the grocery store, really plugged into this assessment tool, and we see Maurice. And the things that set up Maurice is that this is a gentleman who has an anxiety disorder. So that sets up Maurice's behavior. Something else that is a setting event for Maurice is that the behavior occurs worse when the store is crowded, and also when he's feeling nervous and overwhelmed. So these are the conditions under which behavior is more likely to occur, right? This is not sufficient enough to cause the behavior, but there are things that make behavior more likely. And then we see the antecedent or the trigger. In other words, what makes the behavior happen now as opposed to some other point in time? And for Maurice, it may be that he can't find the item he's looking for, or people stand too close to him. So what does he do? Knocks things down, crashes the cart, he screams at people. And people may ask him if he needs help. Maybe his direct support professional or his staff that is accompanying him to the store may tell him to calm down, maybe ask him to leave, maybe other employees in the store may ask him to leave. And so we look at all the information that's in the assessment, and we start to get a better sense of the kinds of things that are happening in the context of behavior, right? We're not just looking at the behavior, we're looking at everything around the behavior. In just a minute, we're gonna go back and look at some support planning for Maurice. But this tool is really helpful because it helps us to break down not only how the mental health factors are contributing to behavior, but also how we get a better understanding of Maurice, right? Not just the behavior, but really how the behavior is serving Maurice and how we can be more supportive of him.
Melissa,
So,
can I
yeah, of course.
Yeah, I'm going to add something in on this. I actually think that this particular kind of effort does lead an organization, especially a team of people could actually sit down and do this as a team, working with a person who has some challenging behavior, to really try to help them determine if in fact there is a true mental health component to that. And frequently what they will find is in fact there is. But the reality is this kind of planning right here, it's a simple one-page form that can be used by frontline staff that can really help staff shift the conversation from a set of behaviors to now a person who needs a more positive approach in their practice. And I think that's what I like about this tool. It's simple, it's easy to use, and it can help build some teamwork to shift the mindset of a team from, hey, this person's really off the wall, to, this person needs some positive practice to really change their behavior. So.
Absolutely. We want to really shift that thinking from just the behavior as the unit of analysis to the entire person as the unit of analysis. And often we say that we're being person-centered, and we really want to make sure that we are being person-centered. And some ways that we can do that is to improve our assessment practices, right? Really look at how behavior is indicating mental health needs, right? If the things that we're doing to improve behavior are not working, we need to improve. We need to look more broadly, not just trying to respond to behavior or manage behavior or change behavior, but look more broadly at the context and those underlying things that could potentially be leading to behavior. And also look at culture, look at linguistic barriers, look at the kinds of things that we are offering as solutions, right? If we're going to be person-centered and we're going to be positive in our practices, we really need to think more specifically about, for this person, why might we need to be really specific and person-centered about some of the solution-oriented things that we do. And Tony's gonna walk us through some conversation around treatment efficacy just a little bit, but data-driven recommendations, right? It's really common for us to want to be helping and say, this is working, this isn't working, this plan isn't working, this is getting better, this is getting worse. But we want to have some real data-driven information around, well, what do we need? What do we mean by that? And we want to do that by really including DSPs, our direct support professionals, at each step, because they have the most current and the most accurate information. So some micro ways, some really close ways that we can prevent behavior and look to be really person-centered is recognize those signs and symptoms, right? Look for ways to eliminate or remove those antecedents and setting events that we can, and accommodate and modify those things that we can't. We want to support the person to the best of our ability by recognizing ways to equip people with those tools that are going to help them in these everyday challenges that they encounter, right? Preparing for and minimizing antecedents, building in predictability and structure, supporting people with relaxation and coping skills, visual cues, visual tools. And let's see what this looks like when we start to put it in action. And here's Maurice again. So some real specific setting events, interventions that we can do for Maurice. We can shop when the store is less likely to be crowded. I know now, especially in this post-COVID age, we have so many different ways that we can purchase our groceries when pick them up online or order in advance, or we can find the days when there's hours that we can go and there's less likely to be people there. But also in supporting Maurice and making his world bigger and helping his life get better and helping him have a better quality of life, supporting him to go shopping in the store if this is something he wants to do, building in those anxiety supports, practicing relaxation when he is calm so he can use those skills when he's not calm. When that trigger does enter the picture, he can use some of those things, right? Maybe he has a list, carry earbuds, listen to music in the store, make those noise be less impactful, those crowds less impactful, really minimize the impact of the trigger, engage in some deep breathing. Maybe he needs prompts, maybe in the future he can start to have the skills and regulation to do that on his own. So instead of the behavior we see in the top row, he can ask for help. He can review his options. If the outcome of his behavior before was to get help or leave, he can certainly get help or leave and now start to initiate that on his own. Leave the store, come back later, try again next time, get the help he needs. We want him to be able to escape that stress and anxiety, right? We never want to tell people that they can't have attention, they can't have options to make themselves feel better or get their needs met. We just want to support them through a process that's going to help them get there better and more safely and build those skills. And we want to help have those DSPs with us along the way, because as Tony says, that's how we really improve practice, by including direct support professionals every step of the way, both in our assessment component and in our planning component, so that staff are more likely to follow plans that they were a part of being included in. And then we improve relationships, and then we're going to improve behavior and mental health outcomes for people that we support. So those are some micro things that we can do sort of in the moment, everyday ways that we can help people that we're supporting. And Tony's going to talk us through some more macro ways that we can build capacity in our agencies just to have more positive practice as a whole.
Okay, hi everybody. Let's just take a look at this slide real quickly before we change to the next one. But building skills, building competency, creating a responsive system. For a lot of us, we came into this field with the idea that we could work with people with developmental disabilities and do a great job with them, and that just through our sheer luck, we could shape or change some behavior and help people do better in the community. And that really defined the community group home movement from the 1980s to the 1990s. And now what we see is that we have way better ability to build skills for frontline staff and families, and also even better ways now to build competency. So starting in 2005, 2006, there was a lot of planning through the National Association of Dual Diagnosis to create both a credentialing system and accreditation system for organizations that to help build competency within staff, as well as on a macro level to build competency within an organization. Because you could spend a lot of time building competency within staff and still have a very unresponsive organization that isn't really concerned about the persons that they serve, or not concerned about the aspects of the care that's being provided. So what we want to do is we want to do all three of these things, okay, together. We want to build skills, we want to build competency for our staff, our clinician staff, our frontline staff, our home office staff, especially when it comes to residential agency, but also then making sure doing all of that actually helps to create a responsive system. Melissa, next slide, if you could. And again, on a macro level, what we want to do on a larger scale level is to have an organization that promotes that. If you're saying that you're promoting positive practice, what you need to do is actually build a toolkit, okay? And in that toolkit, you have to have some capacity of teams to address mental health needs. So when I came to Welcome House in the late 1990s, and I realized that, in fact, we were serving a lot of people with dual diagnosis, for example, and we had one psychiatrist that was helping support us, and at the same time, we had no clinical staff, and we did not have the ability to address mental health needs quickly or in a very positive way. We were reactive. We weren't proactive. So what we've done over the years is to really sort of build a larger clinical team, now having sort of 4 social workers that work at this organization that really see clients from where they are at the moment, and then help educate staff about some of the care needs that those individuals may need in a group home setting, but at the same time also see them in counseling and try to address their mental health needs, along with working with now 3 psychiatrists and a variety of other mental health professionals from the outside. So supporting individuals during changes in medication or other intervention strategies, incredibly important, because we know that from working with people that we support that they're going through a variety of medications sometimes 1, 2, or 3, and doctors are looking for sort of an appropriate medication regimen, and sometimes it takes a long time. It could take more than a year to get a person stabilized on medication, sometimes longer. So the other thing is finding and developing tools to document changes in symptoms and track effectiveness. We're going to talk about this at the end of the slideshow today, but these tools that we're working on are things that we could get our frontline staff to engage in a conversation with a prescriber of medication about the signs and symptoms for an individual with a developmental disability who has a potential mental health problem. So all of those 3 things together really help build a toolkit, and it is a macro sort of level approach, but as an organization, I think that organizations need to shift in this direction to really help deal with, I think, is an explosion of mental health needs in our industry. So next slide, if you could, Melissa. We know that you know this, and I know this, and Melissa knows this, but we all know that, in fact, a lot of mental health issues are not necessarily mental health issues, but they're medical and health issues that are popping up. And, people with developmental disabilities who have very low communication skills can be suffering from pain. They could be suffering from something as simple as acid reflux. Oh my God, how simple is that? Well, if they could only tell us that, in fact, their stomach was upset at night, and while they were sleeping, they couldn't sleep very well because they had acid reflux, or they had some pain in their body or their foot or their leg. If they could only tell us that about that physical discomfort, we could resolve it and maybe deal with it right away, but sometimes they can't. And what we have to do is we have to look for those changes in sleep habits and physical discomfort and really start to educate our staff about piecing together those questions that they can ask as part of positive practice about how this individual is experiencing life at this particular moment. Things like sensitive to touch, or changes in energy level, or digestion, breathing, consciousness, discomforts, an unsteady gait, an unbalanced walk, or recent falls. All of these things are signs and symptoms that a person could be having a medical issue. And what you are seeing now is a behavioral issue. And what you could be experiencing is a person in a mental health crisis, but it could be due to a medical or health-related issue. And we have frequently confronted this in our own organization about how we need to look first at these particular sets of criteria, the medical health aspect, getting a good sort of diagnosis from a family practitioner or the doctor that is serving the person, and looking at those things first before we go on to the next slide, which could be indicators of a mental health condition. about 60% of the people that we support in our program have some sort of diagnosis of a mental health condition. Some of them right now are a little bit more critical, and periodically during the year, some people could experience a more significant mental health condition and a mental health breakdown that could be quite dramatic. One young lady that we support about every 9 months goes into a deep depression, and her treatment approach in working with her psychiatrist is to get an ECT treatment. It's the one way that sort of brings her out of her deep depression, along with some medication changes and things like that. So we have a pretty good indication for that person of when this is going to happen. We can see the signs and the symptoms and know when it's going to happen, and then work with her family to get the kind of treatment that she needs. But these other things that happen, they can be rapid. There are a number of things that happen for our individuals where there's a rapid onset. There are changes in sleep or eating patterns that could indicate a mental health condition. There's a decrease in living skills or changes in appearance and hygiene. One of the more difficult ones to deal with is the evidence of self-harm. We have a couple of individuals that may scratch themselves or tear skin or do other kinds of things. And when that happens, we know that there's a potential mental health issue brewing and something that we need to address as a team. There's signs of hallucinations or delusions. And there's also, as we've experienced, co-occurring substance abuse. Many more individuals with developmental disabilities are living in the community, sometimes by themselves or with lower staffing patterns. That can lead to an increase in substance abuse, and we have to be aware of that and how that plays out in terms of a mental health condition. I would say one of the big things that we look for are changes in sleeping or eating patterns that really indicate a mental health or a mood, potentially a mood disorder or another kind of mental health issue. And those are things that we track very carefully. Next slide, please. Here's just a simple list of common signs and symptoms of mental illness. These are the bigger ones. There's several more. We wanted to give these to you today because as you take a look at these slides, a lot of these things that you're looking at, these could be situations that can not only happen with the people that we're supporting in our program, but they could be happening with a family member of yours, a loved one, a grandparent, or someone else. So, but unusual behavior, withdrawal, a drop in functioning, problem thinking, nervousness, memory loss. And on the other side, increased sensitivity, mood changes, apathy, feeling disconnected, illogical thinking, sleep or appetite or change. Have many of you seen some of these? In some of these descriptions of signs and symptoms in just family members of your own family? I have, and it's led me to think about what could be happening in that person's life right now. And at the same time, these signs and symptoms could be very prominent in some of the people that we support who have a developmental disability, but also have a mental health component. And when you see an increase in sensitivity or an increased nervousness or problem thinking or a change in functioning, it's good for staff to bring that up and start to draw attention to that. And at the same time, discuss it as a part of a team discussion and really start to educate others about how this person's changing, and we're starting to see these changes, and gee, what do we do with that? So let's the next slide. The psychopharmacology considerations, and I have a question for the audience today. Is a psychopharmacology approach to persons with developmental disability considered a positive practice? That's a question that we have been debating. And what we really feel is that, in fact, the answer to that is yes, it is. Okay. There's a lot of people that would say that medication is just restraint. There's a lot of people that say that people with developmental disabilities have too many medications, that we just over-medicate people. And to some extent, both of those situations can be correct. However, at the same time, if medication is used as part of a positive treatment approach and positive behavior strategies that includes things like wellness and exercise and nutrition, then medication can be seen as part of a positive practice approach. What we are also concerned about, sort of long-term adverse effects of the use of medication, especially when dosages are changed frequently. We have to have a better understanding of psychotropic medications such as antipsychotics, antidepressants, mood stabilizers, anti-anxiety medications, benzodiazepines, psychostimulants, other kinds of medications that are used in our population. And certainly I think a goal for any organization, ours and any other organization, is to try to minimize the use of medications. However, we also know that people with developmental disabilities will frequently need some sort of medication to deal with some of the challenges that they experience, both in terms of their thinking, their cognitive ability, as well as their understanding of the world, and some of their past practices. If they experienced trauma as a young person, it's possible that an anti-anxiety medication may be needed for that person, especially as we begin to work with them in a positive way to help them deal with some of their challenging behavior. One of the things that we talk about in this is that the expectation that the use of psychotropic medications, that they will decrease considerably once people with developmental disabilities leave long-term care facilities, state institutions, other kinds of long-term care facilities, and they will use less of those medications when they move in the community, to me, has never really materialized. I think that's something that we need to pay attention to, and certainly look to be very proactive and also create a positive practice around looking at how medication can be changed over time, lessened over time, and other strategies be introduced over time as well. Next slide. This slide came from the recent conference that was actually happening this week in Ohio, it was the National Association of Dual Diagnosis Ohio conference, where one of our psychiatrists, Dr. Rudrick, Steve Rudrick, who works at University Hospital in Cleveland, and some of his colleagues, Dr. Tom Scheidemantel and Dr. Jennifer Belgard, made just a tremendous presentation here in the Ohio area around the importance of direct support professionals and how important it is for them to build a positive practice, but at the same time bring in information that can give the psychiatrist information about observed side effects. The challenge is that often DSPs and direct support professionals have limited training about medication side effects. We're doing a lot more of that these days, but at the same time, it's difficult to educate people around some of the medication side effects because there's so many of them. And we've got a really wonderful tool that we use here at the agency that does educate and have information on each medication as it relates to those side effects. For prescribers, we should discuss the anticipated therapeutic effects and potential side effects of medications with the direct support professional. This is the doctor sort of discussing in the session with the client and the direct support professional the anticipated effects and the potential side effects, just letting those staff know and letting the client know what those potentially could be. And certainly, at least our doctors are doing they're encouraging DSPs to take an active role in the reporting of those of their observations. That is, can the physician, the psychiatrist in the session really help educate the direct support professional not only about the medication side effects, but also about taking a stronger, more active role in reporting some of those side effects between that appointment on that day, if that appointment's today, and the next appointment is not until 3 months. Can we get the direct support professionals to monitor some of the behavior and symptoms? We are working at NADD on developing some of those tools right now that will help with that. We're going to talk about that a little bit later. But here is one example on the next slide of how organizations can do that. All right, this is the Vanderbilt, the Kennedy Center at the Vanderbilt School just has a fabulous resource of a number of great resources and materials. And one of those materials within that website, and I encourage people to take a look at their IDD toolkit. It's fabulous. I know, Melissa, you and I have looked at all the different tools that they have, and they have really developed some very sophisticated tools. This one in particular, though, if you look at it, it is a psychiatric symptoms and behavior checklist, exactly like what we're talking about. So to get to a more positive practice and a more macro level sort of practice for an organization, having this filled out prior to the psychiatric appointment is really a very good resource. Here's the challenge with it. Getting a direct sport professional to fill that out, all right, what you're looking at right now and some of the others that we're going to come up with is a challenge, okay? I'm going to be honest with you. A DSP sitting down to do this prior to a psychiatric appointment could be a great challenge. If you have a program staff or a nursing staff or a clinical staff person, some of those individuals might be able to fill out this psychiatric symptom and behavior checklist. And I will give you an example in the next slide. If you take a look at the next slide.
So before we move
Yes.
on, Tony, I just wanted to mention that the Vanderbilt IDD toolkit, this example that we're showing you, it really focuses on behavior and psychiatric symptoms because we're really focused on mental health for this particular presentation. However, there's a lot of different tools that also deal with some other health-related, non-mental health tools that you can use to track signs and symptoms that would also be helpful. So as Tony's saying, you know, some of this you might need different staff folks and different individuals depending on what their job role is. But in terms of those initial frontline behavior observations, this tool that you're seeing here, it's a really useful tool. We're going to look at some others, but for sure, look at the IDD toolkit because it does provide some other great examples.
And Melissa, these checklists are actually free on their website. Yeah, you can
They're
actually.
free and they also come with some great tips and guidelines about how to use them, when to use them, and of course, with all things, they do advocate that team-based approach.
Right.
Because with all things, it is, I mean, a DSP or any staff, it is difficult to complete something like this on your own. But as you would with any other tool, if you get together as a team, all the pieces of the puzzle start to fit together, and that's how we have the clear picture.
Yeah.
And this is the next tool that Tony was referencing.
Yeah, this is the tool that we developed.
Your agency's tool?
Yeah, that's right. It's an agency-specific tool. It's what we used many years ago when Dr. Rudrick was a primary psychiatrist for us. We were using this particular tool, but again, it was not our frontline staff that were filling this out prior to the psychiatric appointment. At that point in our program, we had probably 8 or maybe even 10 program staff. They're called program specialists. They're actually working in each of our group home settings. We have like 46 homes throughout the Cleveland area. And back then we were using program staff to actually fill this out. And the program staff are actually going with the client to the psychiatric appointment. With the cutbacks in our organization and cutbacks in staff and cutback in funding, those positions went away. And so what happened was we stopped using this tool because we couldn't get our frontline staff to connect with some of the different areas of this particular tool. And I wouldn't necessarily use this tool today, but what we were thinking about doing is changing this tool to make it even simpler in terms of its language and its ability. But if you look at the physical signs and symptoms on the lower left-hand corner, you will see that some of those signs and symptoms are similar to what was looked at in the Vanderbilt assessment from before. So again, I think that using a particular tool like this or adapting a tool like this is really, really helpful. Melissa, let's look at one more tool, okay? This is actually, this is called a MOSES, the Monitoring of Side Effects Scale. It's an actual scale that's used in the state of Washington and also available online and used by quite a few psychiatrists. Actually, Dr. Rudrick used this in his practice at a state developmental center here in the Ohio area. but again, it was not filled out by the frontline staff. Usually in this particular case, nursing staff are filling it out. And nursing staff are filling it out prior to a visit with a psychiatrist. The reason that we're bringing these all up to you today is that what we would like to have a discussion with you about at some point, and also in general with our colleagues at the National Association of Dual Diagnosis, is to really try to develop a tool that as more and more people are living independently in the community, as more and more people live in non-group home settings, that they could utilize a particular tool that would be easier and simpler to do and to use. So again, that's something that we're working on right now through NADD, and you guys may be part of that study in the future. So final couple slides. We want to acknowledge the importance of the NADD Direct Support Professional credential. It has 5 particular competency areas: and assessment, observation, behavior supports, crisis prevention and intervention, health and wellness, community collaboration, and teamwork. We have a few hundred DSPs across the country that are part of this new credentialing system and have gotten certified through the system. And we're very excited that we're making it available and trying to broaden our direct support professionals that are part of this. So I will say that, in fact, one of the key elements that we've talked about today to make positive practice work is having all 5 of these in place is really critical, but having assessment and observation is specifically what we talked about throughout this entire session. And also, Melissa focused a lot on behavior supports, but what we will also talk about in the future are things like how a health and wellness approach could counter the need for extensive uses of medication and could create a positive and proactive practice going forward in the future. Melissa, next slide. And then finally, when we talk about collaboration and practice, again, a more macro level approach to creating a positive practice to shape change is really talking about all of these aspects in this particular slide. Training should include a variety of these areas, and that also should include individuals that will mentor direct support professional staff, will coach direct support professional staff, will help guide and provide instruction to direct support professional staff, because at the end of the day, Melissa and I have said this in many conferences before, at the end of the day, when it comes to working with persons with a dual diagnosis who have challenging behavior and mental health issues, a clinician may see them once a week, once a month, but every day they're going to come in contact with a direct support professional who is going to be dealing with a challenging situation and will need help and guidance and support for that individual that they're working with. So we'd like to thank everybody for being part of the session today. We're going to, maybe have some time at the end to answer some questions. And here's our contact information here. Melissa's at Rutgers University. I'm here at Welcome House in Cleveland. And we really want to thank everybody for being part of this session today on how we can, as an organization, and how we can, as individuals, use positive practice to shape change. So Melissa, any final comments?
No, thank you all for your time. We thank you for being with us, and we wish you the best, and we're happy to share the materials with you and hear from you about what all you've been doing as well.
Thank you.
Thank you very much.